Good evening, everybody. My name is Dr. Jonathan Nikozisas, and this evening I'll be reviewing with you my presentation on manual osteoperforations and high-frequency vibration. By way of disclosure, I am not employed by any specific dental company, and I own no stock or interest in any dental company. Neither do my family members, and I have consulted for products in both Propel Orthodontics as well as Align Technology. I am being compensated for this as well as previous presentations, but this way in no shape or form will affect my presentation to you, and I will give it to you straight up and honest as I always do. By way of background, I can probably skip over this in the interest of time, and so we can get right to it. And I do offer some coaching and consulting services that are available on the web. But I like to think of this whole concept as what I call the fourth order of orthodontics. And that means that, currently as orthodontics, or preceding this technology of osteoperforations and high-frequency vibration, we talk to teeth by simply applying a force into the host tissues by applying a force, and the host tissues, the periodontium, reacted after the fact. And it was a very crude, very basic way to speak to the host tissues. And the fourth order of orthodontics is truly our ability as clinicians to augment the biology, the tissue response preceding force applications. Prior to applying our forces, now we can augment the patient's biology, the periodontium, to our advantage and the patient's advantage. And this has led, and I truly believe that osteoperforations, micro-osteoperforations, and high-frequency vibration are truly the leaders in this. And the benefits of accelerated orthodontics are pretty obvious, that you've got fewer office visits. That means less time off from work, reduced patient burnout. When there's shorter treatment times, you obviously have much less likely to have hygiene issues. And I term this the orthodontic vortex. Over the last several winters, the temperatures are very cold here in the Northeast, and we turned up the polar vortex with plunging temperatures. And I term this the orthodontic vortex because truly there is a plunging number of office visits to complete a case, while inversely, as a result, inversely increasing the profitability per visit. And so for me, that means that reduced office visits, increased profitability per visits, no braces with Invisalign, and this is truly the fourth order of orthodontics combined with Invisalign, no braces, is truly a marketing strategy unlike anything else before in our industry, and it has truly allowed me to be unique in Central New Jersey, to reinvent my mature practice, to set myself apart from others in the area. And you're here today, this evening, to embrace this technology, to learn how to make your practice stand out. Now, when it comes to different techniques and approaches to facilitating, accelerating tooth movement and augmenting the biology, there are doctor-controlled and patient-controlled. And with the doctor-controlled, you've got corticotomies, and all this works. But certainly when you look at corticotomies, it's very invasive, it's expensive, there's a lot of recovery time from the patients, there's pain, there's swelling. Requires another doctor on board, another specialist, and a lot of recovery time, but this works fine. Then there's piezosurgery, and with that you can either raise the flap or not raise the flap, and cut right through it, but it's a little bit more invasive. It requires typically a specialist, unless as an orthodontist you want to train how to use this. There is a pretty high upfront cost for the armamentarium for the piezo surgery unit, and extensive training that's involved. And then there is the beautiful, simple approach with manual osteoperforations, and it is truly microinvasive. It is very minimal costs. There's almost no startup costs, minimal training, and we are all dentists before we became orthodontists, and so this is really right in your wheelhouse, or should be. And with manual osteoperforations, we know that orthodontic tooth movement is indeed controlled trauma. and we need the process of inflammation to move teeth. So when we apply a force, it insinuates trauma in the periodontal ligament, and with trauma you get an increase in all these cytokine expressions, secondary messengers that are absolutely necessary for bone to remodel for this whole process. And with inflammation, the bone remodeling rate increases and the bone density temporarily decreases. And so we know as orthodontists we apply a force and we get constriction on one side and stretching on the other side. And when you have nice light forces, you get frontal resorption where the periodontal where the osteoclasts are recruited from the periodontal ligament space, as opposed to heavy forces, and you get undermining resorption. There's a longer recovery time. And so, you know, this is stuff that we all know and take for granted really every day in our private practices. If we use heavy forces, you get undermining resorption, you get cell necrosis and vascular obliteration of those areas, and it becomes a cell-free zone, and you have a lot of hyalinization and a lot longer recovery. And so this whole cascade of events we know that occurs from a differentiation of osteoclasts and eventually osteoblasts to build bone, and we get resorption, reversion, and formation, and eventually remineralization. But what is it about that whole cascade of events that we can use and harness to our advantage to truly elicit the fourth order of orthodontics? And so the landmark key study out of NYU, which was published in 2013, took 20 patients, and they were all Class 2 Division 1, and they had one bicuspid extraction, and they retracted the teeth, and they used the split mouth design. So on one side they had TADs with calibrated springs of the same force levels, and on one side they got manual osteoperforations, and on the other side they did not. And they followed them for a day later, which you see in illustration B here, which is 1 day following. Note the wonderful recovery. There's really no downtime. And here on the top, illustration A is immediately following the osteoperforation, so there's really not an issue. And in illustration C, you see 28 days later. What you can truly appreciate is the visual increase in movement, and with the more space mesial to the cuspid. And so then they look at the gingival crevicular fluid and measured the amount of inflammatory factors that were released on the side where osteoperforations were performed, as compared to the control side where nothing was performed other than normal orthodontic tooth movement. And indeed, they saw a nice increase in all these inflammatory markers, all these things you've forgotten about since residency: cytokines, expression, interleukin 1 through 12, etc. And it showed that these osteoperforations, this effect, this elevated effect of cytokine release, stayed for a good 10 to 12 weeks and stayed elevated. And they also found in this research that there was a radiating response of about 6 to 10 millimeters around the site where microosteoperations were performed. Continuing in this study out of NYU and published in November of 2013 of the AJO, it shows that there is very little difference in reporting of pain from the experimental side to the control side. And when you look at an illustration, when you have osteoperforations as shown by the black marks here, there's simply an increase in osteoclastogenesis, meaning a recruitment of cells to differentiate into osteoclasts to basically, kind of eat away at the bone and to allow the bone to remodel faster. So the conclusions from the landmark study were that MOPS, microosteoperforations, or manual osteoperforations, significantly increase the cytokine expression that lead to more osteoclast differentiation. In this study, it showed canine retraction of an increase in 2.3-fold compared to the control group. Very little difference in pain was reported, and MOPS are effective, comfortable, safe procedures used to accelerate movement during orthodontic treatment, and they claim that it could reduce treatment by as much as 62%. And so again, here's the synopsis, but AJO-DO, November of 2013. So the conclusion from this study is that we know when we apply a force, we get inflammation, cytokine release, bone remodeling, and tooth movement. But when we add osteoperforations into the mix and elicit the fourth order of orthodontics, augmenting the biology preceding force application, you get an increase in inflammation, increase in cytokine expression and release, thus an increase in bone remodeling, and the net effect is orthodontic tooth movement that is accelerated. And so when it comes to manual osteoperforations, there are several different approaches onto the market. There's kind of the beginners where it's single use. You can dial in your depth, and there's a retractable sheath that goes to certain depths, and when you reach your depth, it has a light that lights up. And this is single use. You dispose of this whole thing. With the reusable handle, this blue handle at the bottom is autoclavable. You press a button, you eject the tip out, and there is no light here, but simply just some striations. And then there's the power driver, which you'll see a video on in a moment, but where instead of manually doing it, it's a power driver, and you set the settings, and you simply go in there and make your manual osteoperforations. So the benefits of MOPS are simply that for the patient it's much less invasive. It can be performed chairside in a few minutes, can be used and indicated with any modality of treatment, aligners or braces, buccal or lingual. No patient recovery time at all. There's no stitches, it's not surgery, there's no swelling, there's no follow-up, there's simply no downtime. And as a result, I see my patients every 4 or 5 months and hand out aligners, and everybody wins. The practice benefit is that you can truly try to attract people that would not normally seek treatment otherwise. And getting back to the whole Invisalign aligner therapy and microosteoperforations, this is just a fantastic way for me to market myself. You can certainly incorporate a premium. It's just been a win-win for everybody. And much like other aspects of periodontal procedures, you simply want to evaluate your areas with X-ray, with clinical assessment, have the patient rinse with chlorhexidine, and you can anesthetize. You can do it with topical and local infiltration. I tend to use both, where I put topical on for about 2 minutes, let it sit for a minute or two, and then I go in and give infiltration. And that's been wonderful for me and my patients. And in the JCO in 2015, I was very fortunate to be part of a wonderful article regarding compound topical anesthetics in orthodontics. So I would reference you to that, just so you are adept and have full knowledge of this. And so there are many different formulations out there. I tend to use something that's been known as the baddest topical in town, and I'm not here advocating for it, but this is just what I use, and here's some of the contact information. And here's me on an early Propel patient doing osteoperforations using that driver, it's pretty simple. He is numb, very simple procedure, and it's very well tolerated and accepted by the patients. So again, in my experience, most patients require 1 to 2 treatments, and really now with high frequency vibration, that is down to 1, and then with high frequency vibration, it has, in my opinion and in my practice, has negated a 2nd or 3rd treatment. But if you choose not to use high-frequency vibration, which we will get into momentarily, the user requires at least 1, maybe 2, depending on the complexity. If I'm doing a whole quadrant, I will do 1, maybe 2 perforations per site because of this radiating effect. If I'm doing 1 tooth and perforating, manual osteoperforating around this tooth, I will maybe at least do 2, if not 3, on either side, simply because I do not have that radiating effect from adjacent teeth. And then I typically redo it, if necessary, about every 4 months, and it's been simply wonderful. And where do you perforate? Simply in between the roots. And you can go into the fixed tissue, you can go into the unattached tissue, and you can do it on the palate if you'd like, to help facilitate the eruption and the traction of palatally erupting cuspids into the archwire alignment. And typically, and this is just a guideline, I mean, the goal is ultimately to perforate the cortical plate of bone into the medullary bone And think of this manual osteoperforation simply as a displacement of medullary bone. It is not a cutting. It is not a bone. It's not a burr that goes in and has a nice clean, leaves a nice clean cylindrical path from where it was, where blood's going to then coagulate in, and it's really going to take a lot. And that's a true insult and true trauma, and that's going to take a much longer time to heal. But rather, manual osteoperforations are simply a displacement of the medullary bone, and there you get this nice fracturing and radiating effect of inflammation. And so as a guideline, about 3 in the front, 5 in the middle, and maybe back by the second molars. On the lower, you might go about 6 or so. But here's some, actual practice, and here's immediately following. This is just, real simple. This is actually my patient. This is immediately following. And you can see I'm in the fixed and unattached tissue. And then here we are 30 minutes later. So you can certainly appreciate that there is no downtime. Patients can leave your office, go back to work, go pick up the kids, go play tennis, go to the gym, go to the grocery store, go and do whatever. It is very important that you tell your patients to only take Tylenol, because if you take anything else, aspirin or non-steroidal anti-inflammatories, it will negate the inflammatory response that we are trying to stimulate. So the benefits of MOPS, here's a great point. This patient came to me from the Doctor Locator, from an aligned company and aligner company, and then they went to my practice website and they saw my information about accelerated orthodontics with MOPS, and they came in for a second opinion. And I treat this adult in 7.5 months, and this is before high-frequency vibration. So in today's world, this would be 1 MOPS and then use of a device that delivers high-frequency vibration. And so this adult here, some periodontal concerns, and the periodontist would like him to get treatment prior to orthodontic treatment, prior to any periodontal procedure. So let's talk about where I'm doing these MOPS. And so for a case like this, where it's simple class 1 crowding, I basically went in from 4 to 4, upper and lower, 1 perforation. And certainly on the lower anterior with this crowding, it might be difficult to get in between, but I did 1 MOPS, mesial to the 4, mesial to the 4, at each site as best as I could. And he absolutely loved it. And here we are at stage 12. And stage 18, and note which tooth didn't track well. That darn lateral incisor, because I did not have a sash attachment on it. And so at 18 stages, we do a little E-plasty. Here's 5 months of treatment. 5 months of treatment from initial to here with 1 MOPS. And then we go to refinement. I put a sash attachments on to rotate that distal in, and I'm done in 7.5 months. And he went ahead and got his grafting done from the periodontist next door. But you can see the subtle changes where I applied some labial root torque to tooth number 26. I rotated the distal of number 10 in with the sash attachment, tidied a few things up. But again, a wonderful example of somebody who didn't want braces and came to my website and found out not only about aligner therapy, but also accelerated treatment with micro or manual osteoperforations. And so what? What's the big fat deal to us as a clinician? Well, we did an exam records consult in about 40-45 minutes with digital scanning. Second visit, bond attachments. Now, he elected to do the MOPS procedure that same day, but this was a 30-minute appointment for me. Third visit, MOPS, remove attachments, scan for refinement, bond attachments, give aligners. Visit number 6, remove attachments, impression for retainers. Visit 7, bond permanent retainer on the lower and give retainers. And so if this is my fee, and this is what I charge for 2 MOP procedures, in today's world I charge $650. I personally found that the $700 mark has been the threshold, the crossover point where people just have not been as readily accepting of this treatment, and that's just in my marketplace. I could be wrong, I could be selling it for cheap, but this is where I am. So that's my total fee. My hard costs, my Invisalign fee less my rebate of about 34%, and that's my fee for customized aligners. Now this is about 1,100 and change. My two tips for my MOPS procedures are $220, retainers, miscellaneous costs. Here are my hard costs to treat the case. So when you take out my fee minus the hard costs, there's my net. You divide that over 7 visits. Here's my profitability per visit, $800 profitability per visit. If I remove the initial exam visit as well as the place retainer visits and just focus on the visits where I'm actually moving teeth, now that goes down to 5 visits and my profitability jumps up above $1,100. So that is what. And so it is truly a great thing. And so profitability per visit is great, but it doesn't matter if you've got holes in your schedule. And the beauty of both of these systems together, it's like chocolate and peanut butter. It's like Reese's peanut butter cups, two tastes that taste great together. And it is just a great way to capture people and bring them in that would not normally seek treatment otherwise. And so profitability per visit is great, but I've got holes in my schedule, and you know what? With all the aligner therapy that I do and the micro-osteoperforations, manual osteoperforations, I got more capacity in my schedule than ever before, but I'm doing many more starts than historically I've ever done before. So when it comes to profitability per visit, let's look at another example and an assessment here. I've got 18 months of treatment at $5,500. This is just an example. If my hard costs are $1,200, that leaves me with a net of $4,300. So you're going to see how the number of appointments based on your frequency that you see a patient really affects your profitability per visit. If you see that patient every 4 weeks, 20 appointments, that's your profitability per visit. If you double it to 8 weeks and you finish in about 11 appointments, that's $425. 12 weeks, basically 4 less appointments, you increase it about 50% up to $615. So seeing a patient just 4 more times can make a difference of a total loss of about $700 to $800. So the difference here is about $200. $200 per visit times 4 visits. That's your potential loss and profitability per case when it comes to profitability per visit. So let's make another assumption that 20% of your cases that you are in your office that you see any given month are past their estimated treatment time. So if you start 200 cases a year, that means you've got 40 active cases that are past their treatment time. And using the above number of 4 additional visits to complete the treatment, that's a decrease in $750 profitability per these 40 cases. Now, if you add this $650 less in profitability times your 40 patients that are overdue, that means that roughly you've got $31,000 in monthly scheduling inefficiencies. Note, I did not say loss of profit. I said you've got scheduling inefficiencies, people that are clogging up your schedule that really do not need to be there. And that certainly affects the bottom line. It affects your ability to book new exams. It affects your ability to take a day off, for goodness sakes, if you really want to go fishing. So my good friend Thomas Shipley has some wonderful articles, and one of them was an orthodontic practice, and he talked about, and this is very profound, for a nominal investment, of $6,000, you get a kit of about 48 tips or 48 drivers, and if you're doing 1, maybe 2 per patient, you can affect 25 to 35 patients with that $6,000 investment, as opposed to spending $1,000 on a vibration device that you're only going to affect 6 patients. And so when you're affecting this many patients, that means you've got 25 to 35 fewer patients in your schedule each month. That means you've got 6 to 9 fewer adjustments every week. That means each afternoon you're freeing up, a good 3/4 of an hour of chair time. And that's profound. So what does this mean? Almost an immediate, huge ROI, return on investment for minimal investment. Instead of spending 6 the large to treat only 6 patients, you can spend $6,000 and affect 25 to 35 patients. That's awesome. So here's a video regarding the PT. It's about 2 minutes long. It's the power driver, and you can listen in.
Hello, my name is Dr. Jonathan Nikozizis, and I will be showing you how to perform micro-osteoperforations using the Propel Accelerator RT driver. Evaluate the treatment area on the patient. Identify the roots, the mandibular nerve, and maxillary sinuses. After receiving your patient's written consent, have your patient rinse twice with chlorhexidine for the duration of 1 minute each time. Anesthetize and propel with the Accelerator RT driver. To ensure your patient's comfort, anesthetize the treatment area using either a topical or local infiltrative anesthetic. Once you have assured that the treatment area is anesthetized, remove the tip of choice from the sterilized packaging. To insert the tip, press the release button on the driver and slide the keyed end of the tip into the bottom of the driver, then release the button to lock the tip in. Microosteoperforation depths are determined by bone and soft tissue thickness. Microosteoperforations should penetrate through the cortical plate into cancellous bone. Hold the driver to the gingiva while keeping the tissue taut. Rotate the driver clockwise while applying gentle pressure. Continue to turn until the desired depth is reached. Line marks on the sleeve of the open tip indicate depths of 3, 5, and 7 millimeters. Rotate the driver counterclockwise to remove. Where possible, perform 2 to 3 microosteoperforations depending on the proximity of the anatomical structures. Perforations can be made buccal or lingual in a linear or triangular fashion. You may repeat microosteoperforations with Propel every 10 to 12 weeks until the desired movement is achieved. Be sure to provide your patients with aftercare instructions ensuring that they avoid any non-steroidal anti-inflammatories. Tylenol is the only recommended medication should any discomfort occur.
So that was the removable tip. There are two others, as I mentioned. There's a power driver, and so you can certainly find some information on that. So let's get on to some cases here, since we've reviewed the science of MOPS. And here is an adult subdivision class 2 on the right side. I treated her in just shy of 12 months before her wedding with 2 microosteoperforation procedures. Now, where do we perforate here? So she is class 1 on the left, class 2 on the right. She's got a reverse smile line, as you can see here, and more gingiva on this side, on the right side, with a hypermobile lip. And so if you look at the anterior section, you can see how these teeth are super erupted. They are extruded. And so my class 2 correction, you can even see it on the pan. A lot of times with my subdivision class 2s, I often make sure I look at that one side is not super erupted. And so my treatment would be to intrude this to this side. And my mistake I made here is I did not distal rotate the molar here. But getting back to where would I propel, I don't need to do the left side here. And I did the upper and lower anterior because I bring the teeth out, I create space, and I move them back and in. And then I also intrude the posterior teeth here as well. And I end up with some freeway space and then a jump. And so again, perforations upper and lower anterior, and just on the right side on the top and the bottom, but nothing on the left side. I'm using a class 2 elastic. And I get to about 7.5 months of treatment for some progress here. And nice improvement in her smile line. You can see the intrusion of that showing less gum despite the hypermobile lip there. And we're done just before her wedding and I went from basically a 90% class 2 to a 10% class 2, and where I could have enhanced this was done a little bit more distal rotation of that molar, but the ClinCheck was simply an intrusion of the 3, 4, 5, and 6, an intrusion of the lower 6 and 7, and then I did a bite jump. But you can see, look at the improvement of the gingival margins, how much more parallel they are going straight across, whereas the beginning, it kind of goes up in the anterior and goes down here as it goes towards the posterior. We have a subdivision class 3 patient on the right, and I finished him in 5.5 months with 2 Propel, 2 manual osteoperforations procedures, and we see class 3 elastic on the right side here. And where I did the procedure is, again, what is my etiology here? The etiology of my subdivision class 3 is the right side. I'm class 1 on the left, and I basically did the perforations on the upper and lower anterior and just the lower right side. So the beauty of manual osteoperforations is that you as a clinician can better target specifically where you want to facilitate the tooth movement and elicit the 4th order of orthodontics. So again, in this case, I did osteoperforations in the upper and lower anterior and just the lower right, class 3 elastic, and we are done in 22 weeks, just shy of 5 months, and that is awesome. 6 months retention. He was just in. He's about 3.5 years in retention now and looks exactly the same. So let's go through this exercise again. What's the big deal? Here's the big deal. Here's the answering the so what question. We basically go through, and in this patient, I have 1 less visit because I did not have any refinement. Same cost as the previous patient, same lab reduction fee, same hard costs, but with 1 less visit, you see how in 6 visits I have a profitability per visit of $931, and then if I remove the first visit for the exam and then placement of the retainers, it jumps up to $1,400, and that's pretty awesome. Next case, we treated in a 9.5 month progress here for a 4 bicuspid extraction case. Now, please don't judge me by this result. But because this case is about 5 years old, and I would do my ClinCheck so differently nowadays. But you can see where I moved the teeth. I had a lack of intrusion of the upper and lower anterior, a lack of deep bite correction, a lack of torque in the front. And it just, not the best ClinCheck on my part, but, you learn from your past mistakes. And so, but I did several MOPS procedures to get her to refinement in 9.5 months. So 9.5 months, look at the upper, that's pretty decent. The lower, I know my teeth are diverged. And this is with the old plastic. This is with a PVS impression, and this is way before the software has gotten much more sophisticated. So 9 months there, I got to here. Look at the upper roots, not terrible. The lower we know is a challenge, and so we total of 4 refinements here. I had a deepened bite. I'm not thrilled with the result here, but it is decent. It is a long treatment time. But this is a difficult case. So initial 9.5 months and then 29 months to get there. So and certainly I would do things a heck of a lot differently now regarding overbite reduction and bite ramps and etc. Next case, 16.5 months using 2 osteoperforations, class 3 anterior open bite. In this case, I did my manual osteoperforations from basically 7 to 7. Let me back up. In this extraction case, where I did my MOPS was basically on just the anterior teeth, upper and lower. I did not do mops on the posterior teeth. Again, this is a great way for me to target where I would like to facilitate the movement, where I want to facilitate the body's reaction preceding force application to enhance my anchorage control. I mean, look at those molars. They stayed put. There was really no tipping of those forward. So thank you for indulging me there. Getting back to this case, I did MOPS, 2 procedures from 7 to 7. I did some IPR in this patient, class 3 elastics, and what you see here is my MEOW instructions where a procedure where I'm intruding the posterior teeth. The anterior teeth that I am extruding, I move them out, I create space, and then once space is created, I then extrude with simultaneous retraction. And here we are. We started MOPS at stage 9 simply because I remembered to speak about it with him for no other good reason. This is like, I think, my 3rd case I ever did. And at 11 months, we get to refinement in 27 stages. No TADs are used here. But from there to there in 11 months is fantastic. And we get to here, and at 16 months I did some vertical elastics to try to tidy up that occlusion, and we are done in 17 months with 2 MOPS procedures. Again, I did MOPS from 7 to 7 here, probably 2 per site, and did only 2 MOPS prior to the refinement. And here's before and after. And 6 months, 1 year, and he's about 4 years in retention and looks exactly the same. Next case, 5 months using 2 MOPS procedures right before her wedding, and I basically did MOPS here 4 to 4, one perforation per site, and we get her to basically 12 weeks progress, and real simple case, and 20 weeks until the total with 1 refinement right before her wedding. Nice improvement there. Next case was 7.5 months using 3 MOPS applications to help broaden this upper arch, and where I did the perforations procedure was basically 5 to 5. And look at 8 and 9 and aligning those teeth, and this is really just the perfect ability. She is a dental assistant in an office that never refers to me. Well, guess who refers to me now? And I just got her sister, who's starting to work there and just finished up her her assisting program. And of course, we're doing aligner therapy and micro-osteoperforations, but this time she's getting high-frequency vibration. When we get to this point in 5 months, my mistake I made here is I did not apply sufficient labial root torque. And of course she needs a SARPI. I get that. But she refused, and I'm her 3rd opinion. And what are you going to do? Turn somebody away that doesn't want a SARPI? You're going to turn somebody away that doesn't want braces? No, you're going to tell them the limitations of her presentation and her maxillary constriction. But here we are at 7 months of total treatment. I did some up and down elastics to settle the case, and we are a year in retention here, and she's about 3 years plus in retention and looks exactly the same. Next case. 10 months of treatment. I perforated this adult patient basically just up and down around the lateral incisors to bring these teeth into alignment, and we get to refinement. And why this tooth didn't track well is because I designed the ClinCheck to pull down and out the long axis, and aligners cannot pull. And so, but then I designed my ClinCheck properly, and I'm done in 10 months for this patient here. Nice improvement. And there you go. Next patient, 5-month treatment time. Oh, this is a hygienist. Finished her in exactly 4 months. I'm sorry, 5 months, 1 MOPS procedure. And look at that 5 right there. Look how rotated that is. And I get her to refinement. I'm sorry, I finished her in 7 months. This is refinement. I finished her in 7 months. And refinement consisted of simply maybe tightening up some contacts, like real easy peasy stuff. But look at that 5, how I rotated that 5. It's about 45 degrees. We've got a vertical beveled attachment. thicker on the mesial, tapering into the crown on the distal. So my pushing vector of force is coming from the distal across the crown to the mesial, but I made it sure as heck that I created space in my ClinCheck. Now she is missing one tooth, one bicuspid. That's why her midline is so off. But I did no IPR here in this case. Next case, adult crossbite. I did 4 perforation procedures. The key here is to apply labial root torque during the movement here. I did no crossbite elastics on this patient, and where I perforated is basically upper and lower 6 to 6, 1 perf per site. By the way, look at the rotation of the 5 right there, and I get her through 5 months of treatment, and at this point I mistakenly took off the buttons to do the power chain to rotate that tooth, and in 4 short weeks that tooth basically rotated back before refinement. So at 6 months, 25 stages, look at the improvement of the crossbite. No crossbite elastics here. My midlines are off. So how do we correct midlines with braces? We don't do IPR. We put a class 2 elastic on. And so that's what I did in refinement. And in refinement, we are done at 12 months, 1 year of treatment, and the crossbite's corrected. 4 perforations procedure. In today's world, I would still do the perforations, and again I did it from basically 6 to 6, and I would do 1 perforations now and give her a high frequency vibration appliance. 12 months in retention. She's about 2 years in retention, and the tooth that's giving me a hassle is tooth number 20 due to those supracrestal fibers that want to pull that tooth back. And that's where I should have done a fibrotomy potentially. Here's some real quick one-off cases with class 1 crowding, and we get with 3 perforation procedures from Dr. Ben Moralia, and we're basically at this point in just under 11 months. Dr. Thomas Shipley did 1 perforation procedure, 3-day changes, and 6 months of total treatment. Dr. Jean McGill, moderate crowding, 1 perforation procedure and 6 months of treatment. Dr. Thomas Shipley, a great way to help facilitate space closure with 1 perforation procedure and basically 2 months of treatment. And that's pretty darn cool. Another one from Dr. Thomas Shipley, where we simply just align the teeth. We've got 1 perforation procedure, and 8 weeks later, look at that huge improvement. Great case, next 2 from Dr. Shipley, where we take out a Maryland bridge, close the spaces, and he did 1 perforation procedure in a total of 51 days. And look how parallel those roots are. Same similar clinical situation, different patient. Remove the Maryland bridge and get things nice and closed and parallel in 5 months' time with 1 perforation procedure, and you can see where he did it in the anterior region there. Again, blocked out cuspid, 1 perforation procedure and 5 months of treatment, and nice alignment there. And finally, I think this is the last one, 1 perforation procedure, and we're done in 6 months' time. Oh, I was wrong. 4 months, 1 perforation procedure. I mean, real great stuff. So let's go to some braces. So I do use those from time to time. And here is an adult patient here. Chief concern is teeth stick out. He's subdivision class 2 skeletal. Teeth are incompetent at rest. And so I basically took out upper 4s, and a lower right 4 and a lower left 5. And this is my first insignia case, my first attempt at Damon. For 5 months, I basically aligned the teeth. At month 5, I placed TADs, and I perforated in the upper and lower anterior, and then by the lower left 6 and 7, and placed TADs to protract and close the spaces. And I am by no means a self-ligationist guru, so please don't judge me by these awful mechanics. But nonetheless, in 7 months, from month 5 to 12, 7 months of treatment with 3 perforation procedures, I got to this point. I saw him once a month just to change power chains and look at the springs, etc. But basically, I went from here to here in 7 months with 3 perforation procedures. And on the bottom, similar situation, tried to protract here. So at this point, I told the patient, James, we do not have to do this anymore. And from month 12 and 13 to 14, I did no more perforations. I'm sorry, for 4 more months till 16, I did no more perforations, but I couldn't close the space. So at this point, at month 16, I went in and did perforations, and I was able to close that stubborn space. So had I done perforations maybe one more time, I probably could have gotten this down to about 14 months. My occlusion's not, superb because he's a class 2 skeletal with a retrognathic mandible. But overall, I'm pleased with the arch form. I'm pleased with his lips are together at rest now, and I satisfied his chief concern, and a decent improvement of the profile. So let's discuss high-frequency vibration with the 15 minutes remaining. And I've got some publications out there with introduction to use high-frequency vibration. For me, I use it to help seat the aligner better. When you have a better seated aligner, it simply performs better. And when it performs better, when it fits better, you get better patient compliance. And I use it for 5 minutes a day, and it's used to seat aligners. There's different parts to it, from the mouthpiece to the oscillating piece to the charger and wall adapter. You've got different colors, which tend to signal different aspects of the device when it is running, when it's charging, etc. You've got, as well as the device itself, but you also have software to help manage it to ensure patient compliance, etc. But now let's review some research reviewing high-frequency vibrations and its effect on the dental-alveolar process in certain clinical conditions. And so this study shows that high-frequency vibration, when a tooth is extracted, has increased the healing of the tooth extraction site. And it has increased the amount of intermembranous ossification. And also potentially it might have an application in preserving the long-term volume of alveolar bone. Next study regarding high-frequency vibration in different clinical applications or assessments was shown that high-frequency vibration accelerates, caused the bone to remodel nearly twice as much as compared to low frequency. In the high-frequency group, had a nice increase in bone quality over the same time period compared to the sham and other control groups. There was an increase in bone remodeling activity, resulted in thicker and denser bone trabeculae, and localized high-frequency force of low magnitude is able to induce this osteogenic response. Then continuing, another study that bone has the ability to differentiate between different frequencies and vibration types, and high frequency resulted in significant increase in the trabeculae of the bone volume as well as thickness, and bone formation rates in low frequency vibration subjects were not statistically significant, or different rather, compared to the controls. And then when they looked at high frequency vibration on the periodontal process, the dental-alveolar process, and related to orthodontic tooth movement, it showed that after a certain period of time, indeed, there was an increase in secretion of secondary messengers and cytokines that is consistent with an increase in inflammatory response as it relates to teeth undergoing orthodontic tooth movement. And then in terms of discomfort, high-frequency vibration has shown to patients reported a significantly decreased inpatient discomfort throughout treatment. So let's look at some clinical cases. Here we have a patient, class 2, high mandibular plane angle, excessive overjet, TMJ discomfort, lots of pressure on the joint due to her open bite tendency. And look at that high mandibular plane angle right there. And so I treated her with using aligner therapy to intrude the posterior teeth, like the meow appliance, and this is vibration only. This is high frequency vibration only to help seat the aligner, to help the aligner perform better. And suffice it to say that I intruded these posterior teeth, upper and lower, to the point when there was about 5 millimeters of freeway space and intrusion. And at weekly switches, without vibration to help seat the aligner, with the amount of intrusion I did, there was no way that these aligners would seat and fit as well as they did with simply using a device that delivers high frequency vibration here. And this is 12 weeks. And note the reduction of the overjet as the mandible is swinging forward. Patient reports zero discomfort when she switches her aligners out weekly. And I get to 5 months, and her TMJ symptoms have reduced by about 80%. And we see that the mandible has rotated forward rather significantly. At this point, I did IPR here in refinement to bring those lower incisors back and continue the class 2 elastics here. But that's a huge improvement, huge reduction in overjet. And again, I did vibration appliance only to help seat the aligners. And here we are, total treatment time of 8 months. TMJ symptoms completely resolved. No discomfort during the treatment when switching out aligners weekly. And that is simply awesome. Huge improvement. Here is my staff member, just high frequency vibration appliance with aligner therapy, and she's done in 4 months, switching aligners out every 5 to 7 days. This patient here started without anything, just aligners, and I'm not fixing his posterior crossbite. His goal is simply to gain some positive overbite overjet, so he's not banging into these teeth. So for month 0 to 4, he just switched those aligners out. From month 4 to 9, 5 months, I gave him a high-frequency vibration appliance to help seat the aligners, and he reports a significant decrease in pain. He's a psychologist, and huge improvement in the discomfort. And again, this is somebody that started treatment without it, and then in the middle put it on or started using it, and right away he called up and said, I feel nothing when I switch out my aligners. And this was my goal right here, to gain positive overbite, and so he's not banging into those teeth. This patient, late 60s, my goal here is to intrude these teeth. In this patient, I did 1 MOPS procedure. I did perforations upper and lower anterior teeth, 1 perforation, and then on the lower right side, because he's lower left side, because he's class 3, I did perforations here to help facilitate my class 3 elastic that I have. And so 1 perforation procedure and then high frequency vibration device to help seat the aligner. And we get the 6 months, and we are in refinement here. And in 1.5 more months, 7 months of total treatment. Look how well the aligner is seating. Look how much I've intruded those teeth on an adult in 7.5 months. And then he gets those teeth restored. And now I'm tightening up the bottom a little bit. But that is pretty darn cool. And from there to there, I was done with my orthodontics in 7.5 months, and it took several more weeks for these restorations to be done. I'm still tightening up the bottom as it relates to the final restorations. Another adult patient, 1 MOPS procedure, and I did 1 perforations, basically distal to the 3, distal to the 3, gave her high frequency vibration, and I apologize for the records, but she is done in 5.5 months. So with that, I would like to open up the floor to any questions. Please feel free to type them out. This concludes my portion of the presentation. I'd like to thank you for your kind attention, and happy to leave this website up there as a reference to any additional CE resources. But please feel free to type out any questions. I've got the question pane open, and once again, I very much appreciate your kind attention for this evening. First question, How do you handle severe crowding and risk of damaging roots when I'm doing MOPS? Wonderful question. So obviously you have to use your clinical judgment. And so we know from our TAD research that if you happen to nick a root or periodontal ligament, that you're not going to devitalize the tooth. You're going to get reparative cementum in that area, so you're really not going to have a huge problem. But when it comes to severe crowding, sometimes I might skip an area, or maybe I go much further apical into the unattached tissue. Maybe I use my clinical judgment and simply score, if you will, the cortical plate of bone and not enter the medullary bone, just to kind of stimulate the micro insult, if you will. How often do you do perforations for the patients? I typically now only do them once. I only do one perforation procedure, and then I give them a device that elicits high-frequency vibration, because in my opinion, high-frequency vibration is the only research that I've seen that supports this positive effect on the dental alveolar process. When you intrude one arch in a subdivision case, do you extrude the opposing arch simultaneously? In that case that I showed you, the answer is no, because with the Class II elastic I had, I basically had the mandible kind of just swung forward a bit, and it's not just the mandible, but it is the whole dentalveolar process on the bottom. And the beauty of MOPS is that I believe that it allows the teeth to move through the physiologic modeling clay that the dentalveolar bone is. And so in that young lady where I did the subdivision Class II, I intruded those, the upper right 3, 4, 5, 6, and 7. I intruded the lower right 4, 5, 6, and 7. And when I did MOPS there in Class II elastic, it just brought the whole complex forward. And that has worked out very well. Now, of course, every case is different, so don't take that one case in that differential diagnosis that I did for that subdivision Class II as gospel. You have to look at every patient and a treatment plan accordingly. Next question, do you shorten the payment plan with shorter treatment time? I have had 0 issues with patients paying me after the treatment is completed. So, of course, I was worried about that at the beginning. It's a natural knee-jerk reaction. But the way that we handle it is simply say, hey, you're done with your treatment. Are you able to pay the balance in full? I mean, you don't get what you don't ask for in life. And if they say yes, then that's great. If they say no, well, they say, well, we say, well, can, instead of paying out over the next year, do you think you can finish up in 4 or 5 months? If they say yes, then that's great. If they say no, well, then all you're getting is a monthly annuity, cash rolling in, a payment coming in, and you're not having to see the patient. So it's a wonderful thing. And I simply haven't been stiffed. And the 2 times that you might get stiffed or burned, it pales in comparison to the number of patients that are going to continue to pay you when they are done. So to reduce appointments, do you give out all your aligners to the patient without monitoring, tracking too much, and then consider refinement if needed? I'm at the point now because I am not, my cases are far from perfect. But I believe that I have mastered ClinCheck at this point in my career, so I can set something, set it and forget it, and now I'm routinely giving out 12 weeks worth of aligners. They come back in, I might give them 5 months worth of aligners, and and then I see them back when they're done for refinement, and that's that. So where would you MOP for deep bite cases? Certainly the upper and lower incisors. And maybe backed by the bicuspids, but ultimately it depends on which teeth you're trying to move. So what's the differential diagnosis? Is the smile line good in a deep bite, and so you're really just going to be focusing on the lower anterior teeth only? If that's the case, then is it a crazy curve of Spee? Is it also the curve of Wilson that you're going to want to upright? So of course then you're going to want to incorporate the premolars in that clinical scenario. With the posterior crossbite created during aligner treatment, do you cut out aligners distal and run vertical elastics? Well, I would submit to you that posterior crossbites that are, posterior open bites that are created during aligner treatment have nothing to do with the aligners. It has everything to do with a poorly designed ClinCheck. And so there are ways to prevent it, and there are ways to recover from it. When it comes to preventing it, you need to make sure you apply labial root torque, labial crown torque to those teeth in the ClinCheck actively, like I did on that case that I showed you. And you need to make sure that you have a level curve of Spee on the bottom without any iatrogenic anterior interferences that are typically caused by under-torqued teeth. So I could speak on 15 minutes on this subject, but that really comes down to a properly designed ClinCheck. Does insurance cover Propel procedures or high-frequency vibration? I do believe that you can. There is a code for to cover manual osteoperforations. I've done it once or twice, and I know Dr. Thomas Shipley does it. And so I would ask him how he and his staff word it. It's just one of those things that I have not gotten to do, but and you can ding the insurance for that procedure. I do not believe you can ding the insurance for high-frequency vibration devices. Next question. If MOPS is only done on one side of the root due to severe crowding, do you notice a reduced effect? I have not. You know, I have to look at the clinical situation, but no. I typically try to get on both sides, and it just really hasn't been an issue. Last question here. I understand that you have extended payment time beyond the treatment time. How does the shortened treatment time work with insurance? I have noticed for some insurances if the treatment, and then it stops. Oh, wait, does it stop? No. If the treatment time is shorter, their overall payment will be less. Congrats on mastering ClinCheck. Thank you. I'm still learning, by the way. So when it comes to insurance, you know, you can massage that conversation any way you want to. You know, you could still be in guiding treatment, active treatment that's not necessarily retention. You know, retention could be, I mean, you could rename retention, you know, after a year of observation of active treatment at the end and settling. So you could just rename this a settling observation phase part of active treatment. And so I would still put down, to answer your question directly, when it comes to insurance companies and the treatment time, I would still put down your 18 to 20 months, 24 months of treatment time. Now, you know, I know some insurance companies pay a certain amount if you go 18 months, a certain amount if you pay 20, if you go 24 months, a certain amount if you go 36 months. You know, I'm not here advocating what to do other than simply do what you can do to make yourself sleep well at night. And so, you know, I don't routinely put down 36 months. I might put down 20 months or 22 months, and if I'm done in 14, you know, I'm observing for the next 10 months and make sure everything settles just right before I officially go into the retention phase when I really don't see the patient that much. So again, you can massage the conversation however best you would like. So anyway, I would like to thank you for your kind attention, and this concludes this webinar. And thank you all so much, and have a wonderful rest of your week. Bye-bye.